How are
Okay.
things?
You
Good.
know, things are things.
Things are things. I understand.
Yeah.
I
There's
do
our Miss
Oh,
understand.
wonderful. Okay, I'm going to just give her a quick rundown as well before we get started. Um, Hi, Dr. Quinlan. So glad you could make it. I'm just going to a quick thing before we get started. We're not live yet. Do you have a preference on how you'd like to be referred to this evening? If Dr. Quinlan or Maura,
Oh,
if there's any preference?
Maura's fine. Maura, like
Maura's
Laura
fine.
with an
Oh,
M. Yeah, yeah,
oh,
yeah. Okay.
okay, perfect. And then, so it's only going to be the three of you this evening. Our other speaker is actually assisting with a birth today, so she can't make it. So we do have some time for you guys to go a little bit more in depth on your own bios. Terry will still introduce you, but you'll have an opportunity to go a little bit more in depth if there's anything you want to share with our audience today. Great. I will pass it over to Chris. He'll get us live and started. Just for your edification. So we've got people remotely, and then we've got a lovely room of folks here at the Schaumburg Library as well. So I'll help any questions we get from them. I'll just basically read them to you as I receive them. And then we'll be receiving Q&A questions that you'll probably be able to see on your screen. Don't worry about those. Whichever ones we go with, I will also read those to you as well. If we're all good to go, I'm going to pass things over to Chris.
Alrighty. Good evening, everybody. Welcome to my in-person audience and my virtual audience. Hi, everyone out there in virtual land. Welcome to the Schaumburg Library or the Schaumburg Library Zoom account. We are so excited to be spending this evening with all of you and continuing on our Civic Awareness Series, our partnership with the League of Women Voters of the Palatine area. And there's other areas that I am really bad and don't have memorized, but they do, and they will say it and fix my little error there. I'm just here to go over a few friendly Zoom reminders and in-person reminders before I pass things over to the League. For our virtual guests, remember your cameras and microphones have been turned off. I forgot to do an important thing for y'all there. Everyone here is getting a great behind the scenes view of me. For our panelists, you can just minimize that. Don't X out of that for me. Your cameras and microphones have been turned off. If you have questions for our panelists, please submit those to the Q&A, and the League is monitoring the Q&A, and we'll ask those on your behalf, so don't worry about that. If you have questions, you can throw those there. If you're experiencing technical difficulties at home, you can also reach out to the Q&A, and I'll be alerted, and I'll do my best to go back and forth with you and solve any problems you might be having. We've also enabled closed captions for your convenience. If you would like those, you can turn those on or off as you wish using your Zoom toolbar. For our in-person audience, my friend Sam in this green sweater from the League of Women Voters should have already handed you a index card and a pen to write any questions you might have with. And to have those, you can fill them out and then raise your hand, raise the card in the air. Sam will collect them and bring them up here to the podium for Janet so that she can field those to our panelists. And for our in-person audience, for coming on out and handling all our weird technical difficulties, if you would enjoy a cup of coffee, I have put out some coffee because I think we all have earned it. And hey, if you're at home, you have beverages. And I'm happy to pretend that I sponsored those beverages for you. For our in-person audience, if you could take this time to silence all cell phones and any other electronic device that may make noise during the presentation, that would be absolutely lovely. Restrooms and water fountain are located straight out this door. The restrooms right there, and then the water fountain in the center. That's kind of all from me. I'm going to hand things off to one of my partners from the League of Women Voters, Karie Gazowski.
Thank you. Thank you, Chris, for that enthusiastic welcome to all of our friends in Zoomland as well as here on site. My name is Terry Gazowski. I'm with the League of Women Voters, Palatine, Barrington, and Schaumburg areas. And I'm the co-events director with Janet Sonoyka, who will be leading today's discussion. Thanks again for the Schaumburg Library and Chris in partnering with the League on this Civic Awareness Series. A little bit about our League is that it is a non-partisan political organization. Anyone can join or support the League in our mission of promoting civic engagement, voter education, and advocacy on various issues. You can learn more about the League and participation through the website that we will pop in the chat, as well as where to go to vote. We're over 100 years old, but welcome the energy of all ages and genders. Tonight, we are going to explore with our panel, women's access to reproductive health with 3 panelists, Neha, Bhardwaj, who is with Ryan Center Medical Director, Associate Complex Family Planning Fellowship Director, Assistant Professor, Department at Obstetrics and Gynecology, University of Chicago. They will all have a chance to talk a little bit more about themselves to correct my pronunciation and to add to their all of their resume. Karie E. Stewart is a certified nurse midwife, University of Illinois Hospital and Health Science System, principal investigator for community maternal health care, and co-principal investigator for Melanated Group Midwifery Care. And lastly, Maura Quinlan is with Women's Health Medical Advisor for Illinois Department of Health, board certified in OBGYN, and has been in clinical practice since 1996, and most recently at Northwestern University. So I'll hand it off to Janet, my co-partner here, and then we will wrap up after Q&A with our president of the Palatine Area League to complete the session with some news and information around the league after we're done here with the panel. Thank you.
Wonderful. Hello again, everyone. Thank you, Terry, so much for the introductions, and thank you so much to all of our panelists for taking time out of your really busy lives to share your expertise with us today. So if we could just go a quick round in order, if you all want to share a bit about yourselves. Dr. Bhardwaj, if you'd like to start.
I just want to say thank you guys for having me. I really appreciate it. I also am touched. I'm a Barrington High School alumni in 2000, so it's wonderful to be here. I'm sorry I couldn't be there in person today. I am at University of Chicago. I'm the director of our abortion clinic there. It's called the Ryan Center. We also focus on complex contraception. I did a fellowship specializing in both complex contraception and abortion care. I'm also a part of our CARLA coalition, which I can talk about later, which is the Complex Abortion Referral Line for Access in Illinois, funded by Governor Pritzker. But that's it.
Great, thank you so much. Karie, if you would like to share your background as well.
Thank you. And thank you also for having me. I'm Karie Stewart. I'm a certified nurse midwife. I am working on the south side of Chicago in Auburn-Gresham, where we have our most newest federally qualified healthcare center, which serves predominantly Black and Brown individuals and our most vulnerable populations. What I am working on now currently is looking at group prenatal care and how racial concordant care, which is specifically a Black midwife for our Black patients, how that addresses structural racism within the healthcare system, but also gets them to trust us in the system so that we can allowing them to receive the best care possible. In addition to that, we have some community research that we're doing specifically with the clinic that I'm working with, and just focusing on utilizing the providers that we have there and providing collaborative care and using that as a model to address community disparities, really focusing on maternal health and changing how we care for our most vulnerable population. So I'm grateful to be here. Thank you.
That's fantastic. And then Dr. Maura Quinlan, if you'd like to share your background as well.
Sure. I'm also thanks to be here. What a great panel to be part of. I am a practicing OB/GYN. I've been doing it a long time, full service deliveries and surgery and abortion care and all the rest for my whole career. But for the last year, I still have clinical practice at Stroger in Chicago, but I'm the Women's Health Medical Advisor for IDPH, which is kind of a new role to have someone at the state health department who does the work. It's been a fascinating ride. I've been doing it for a year, but anyway, so I clinical and also working for the health department.
No, that's fantastic. Thank you so much. I just want to check one thing with tech for record. Do I want to instigate the record? We're good? Okay, wonderful. Sorry, some back-end questions. Fantastic. I am so excited you guys have such an interesting background. And with all of these different backgrounds, I would like to field this question to everyone. really the big question here is, what does accessible healthcare look like to you? And at what point would you define treatment as inaccessible? Certainly, what one person defines as accessible is not the same across all gender and racial backgrounds. So I would be really curious to see how you as professionals would define accessible healthcare. Karie, if you'd like to start.
Yeah. The nice thing about accessibility is you don't have to go far. And so what I like about the clinic that we have open up is we've really been intentional about having all the services. Now, we are working on trying to have abortion care services. And that's really what access means. All of the services at a location that is accessible to the community in their own neighborhood. And so a lot of communities do not have that. They'll have to piecemeal and go here and go there. And then that sets us up for complications and outcomes that we don't want to see. So to me, it's just having all the options close by, just like we have our grocery stores, our pharmacies, anything that we can get in our neighborhood, we should definitely getting all the options of healthcare.
No, that's great. I think it's difficult in Illinois. I know we're fairly insulated as far as access to or restrictions to women's health care. So nearby, I guess I never really thought of it. Like I drive, I think at least like 30 minutes to get to my OBGYN. And I never really thought of nearby really being as close as my grocery store. So that makes a lot of sense. Maura, if you'd like to share what accessible means to you as a professional.
Sure. I think Karie hit the nail on the head. But when I saw this question, I think that accessible means the standard of care for all patients who need it. And that is just something that's not quite happening now. But I think for a provider to be able to practice the standard of care, whatever that is, whatever the patient needs, regardless of where you live, the religious affiliation of your institution, et cetera. So it's accessible if everybody can get it wherever they go.
Hearing some consensus, that's good. And then Neha, if you'd like to share your definition of accessibility as well.
Karie put it so beautifully. I don't have much to add. I will add that besides accessibility, we also need to look at it's not just access to care, but kind of what the patient wants from a healthcare provider and a healthcare system. So kind of looking beyond access, which you're right, in Illinois, we're so protected and we're so insular. But I think that means that we get to push it a little bit further and look at what patients really want in their providers and in their healthcare system. So kind of move beyond just accessibility.
No, that makes a lot of sense. And in terms of, I know a lot of you guys are working directly in the neighborhoods that are around you. Telehealth is something that's very large these days. As our reproductive care climate is changing, are you seeing any like telehealth avenues in your line of work in terms of making it accessible to people who are outside of Illinois?
I can start that one if you guys don't mind.
Yeah, sure thing.
So this is a topic that's really hard for us as abortion care providers. I would love to see my patients that live in Indiana, which from University of Chicago is only like a short 30-minute drive. We have such a high volume of patients from Indiana. Unfortunately, that would mean that I would need an Indiana medical license. And we've seen that statewide medical boards have actually gone after providers that provide care that may not be comfortable for those to provide or kind of not in vogue in that state or legal in that state, and have come after individual medical licenses. So because of that reason, many of us that practice kind of higher volume abortion care in Illinois don't have out-of-state medical licenses, because we want to be able to make sure that we can still see our patients in Illinois and that we don't have like disciplinary action against us. You know, Governor Pritzker's done an amazing job for us in that way, in this local environment where we are protected as providers to provide patients with care no matter where they come from. And their personal health information is protected in Illinois. But that doesn't extend to us treating patients out of state.
That makes a lot of sense. Karie or if you'd like to add to that, in terms of telehealth, if that's something that are avenues even within Illinois or expanding to like the greater region.
Yeah, no, you're right. We have great access here in Illinois, and I have lots of patients that are across the border, whether it be, Gary, Indiana, or Crown Point, and that's just a little bit ways away. But if I want to, for my pregnant patients who've just given birth, I want to do a 2-week telehealth. I don't want them to come all the way to the city. I can't do that because, there's these laws about insurance and doing things in another state that we do so freely here. And it's really preventing a barrier to care. And so we love telehealth. It's great, but there are also some things that need to be worked out with that.
Very understandable. Thank you. So then in terms of like we've been mentioning, Illinois is very protected in a lot of ways. But even with that, has the overturn of federal protections of abortions affected how you make reproductive care decisions? It sounds like since you're dealing with patients who might not necessarily be from Illinois, is there anything that you have had to decide differently because of this, of potential repercussions or something similar? Dr. Maura Quinlan, if you'd like to start on that one.
Sorry, gotta get off mute. I think it has not, the federal protections have not affected us in Illinois because we have state legislation that made things really not so different for us compared to what it was before. What has had to happen is the ability to manage the influx. We're one of the states that has had the largest number of patients coming for abortion care from other states, because if you look at a map, California is surrounded by mostly states that also are protective, and we are not. The states around us are kind of went one by one. So what's had to happen in Illinois is we can keep providing the care we always have. We just need to be able to scale up a lot. And from a state level, there's been more monitoring, not individual patient data, but just this aggregate numbers to get a sense of what the changes have been here and how we can help from a state health department way.
Mm-hmm. So then from like the perspective of the IDPH, those are numbers that they're tracking. Is it essentially, is the big number, right, that comes to mind is abortive services, but are they also tracking things like pre and postnatal care, or even just general hormone or IVF related? Do you have any insights onto if they are tracking all of these things that are related to it, or strictly more like abortion services?
That's a good question. I think tracking sounds a little scary. And this is not, this is aggregate data.
I mean, like,
so
from a public health
like,
perspective.
Yeah, there's not like Jane Doe, this age, this happened. It's only aggregate, totally de-identified, because for obvious reasons, that patient privacy is really important. But there is the ability to get billing data, to get insurance billing data, just to see the numbers of people who used IVF services. So those that's not new. It's always been possible to get those, just aggregate data on the number of claims for, appendicitis. So all of those things have been reported, but the aggregate, the data for folks who come into the state for abortion care is much more protected and only done in aggregate, like big numbers, that's all. Just for the fear that someone could go back home to a banned state, and that someone could ever find out that they were here. So that's not available.
Thank you for clarifying. Yes, in broad terms of like, or when they were tracking COVID, how many beds are full, who's using respirators, or not who, how many people are using respirators, and in a more of a general public health way. Thank you for clarifying. Oh, I have lost my, yes. So then I would like, sorry, go ahead.
Do you mind if I add one quick thing? If you
don't no, please, by all means. I was about to ask if you'd like to add anything in terms of restrictions from federal regulations.
I will say that the federal restrictions have affected us in a couple different ways. One is capacity. So like Maura was talking about, we ourselves as providers are now just much busier, and we are focusing more of our care on abortion services, whereas we used to do more full spectrum OBGYN care. And it also has been shown the providers and hospitals and nurses that are in states that are surge states, like Maura said, we are the #1 surge state in the United States for abortion care, have actually been showing increased numbers of moral distress and emotional distress in their jobs. So that I do want to kind of honor. Having patients get on a plane with very early rupture of membranes or bag of water breaking at 20 weeks, and then not being able to get care in their home state, getting on a plane and coming to Illinois for care, it affects that patient. It also affects their whole healthcare team. So we've noticed that anywhere from medical students up to nurses to surgical techs, it is very emotionally draining. It's also financially draining. Illinois has definitely put their money where their mouth is, if you will. But it kind of affects a lot of different ways. So the last aspect I would want to say was that we've noticed that younger patients are requesting more. It is more common now, or the rates of younger patients requesting permanent sterilization for fear of getting pregnant has also increased. So there's this kind of general fear that if I get pregnant and I don't want to be, I will not be able to travel to a state or take care of that pregnancy. So there is kind of this distress among patients as well.
No, thank you for sharing that. That's very interesting. I do have 2 follow-up questions for that. In general, because of this increase in distress among practitioners, are you worried are we seeing people leaving the profession in general? Yeah, I'm getting some nods here saying that yes, that's the case.
It's funny. And I just want, this is my dissertation topic. I'm currently working on my PhD, and I think we don't understand the importance of our providers and the effect this has on them emotionally, because they have families of themselves, they have lives themselves, and they take an oath to do this work, but it is very exhausting. COVID has really exacerbated a lot of things that, we knew as providers in the system were not working for us. And then now we, post-Dobbs has just really added to that, moral distress and emotional stress that we have as providers. I'll share, we do a lot of maneuvering that we should not be doing. And that's on a day-to-day base, with our patients, and we could have, 20 patients a day. And that takes up a lot of time for doing the actual things that we really need to do. And so it's really important for us to, put some things in place that not only just protect our patients who have to do all this traveling, but us who have to, maneuver this system for them so they can get the care that they need.
Oh, thank you for clarifying. That's very helpful. And then one other thing I wanted to touch on, Neha, you mentioned that before you were able to give more full spectrum care to patients, and now you're really having to focus, because of this increased capacity, on like strictly abortive services. When you say full spectrum, could you elaborate a little bit what that is? Because I know when we think reproductive care, we really are thinking of, conception to birth, and like that's it. But what does the full spectrum look like?
That's a great question. I mean, my partners and I, we do full spectrum sexual health care. So we deliver babies. Some of my partners aren't so much involved in OB, but they're more involved in gynecology, so hysterectomies, kind of major abdominal surgeries. And what we realize is that those of us that do kind of more specialized abortion care or have like additional training in it, that is where we are needed currently. And so we feel this call that we have to help those patients because other people can do the other kind of fuller spectrum sexual health care. Many of us did trans healthcare as well. And we're kind of losing that because our services are so needed in one specialized area. So it really shows how, in response to these federal restrictions, we are now narrowing our scope of practice because we feel this urge and need to care for these patients coming in. And so it kind of is a ripple effect, right? It puts more of a burden on our colleagues who do more full spectrum sexual health care to kind of take care of these other patients and these lost patients. And the volume is just, it's hard.
No, thank you for elaborating. I think that's a really good example of how I know a lot of people are like, well, this is just a women's issue, or this is just a women who could be, like have children issue, when really it's rippling out, because healthcare, public health, we're all connected. So thank you for elaborating on that. Let's will take me to my next question, but I would like to have a reminder, while we do have some prepared questions, feel free to write down any Q&A questions you have at any time, both for our folks at home and in person. Don't be shy. If something comes to your mind, just write it down right away. But we will get to those if you have them. But so for our next question here, we've been talking about how Illinois is protected. Can you elaborate on how Illinois is currently protecting our access to healthcare? And are there any healthcare rights that are still subject or up to federal regulation in terms of reproductive or other type of healthcare that you work with? Karie, if you'd like to start.
This is probably a good question for Neha.
I was actually going to kick it to Maura because she works with the IDPH.
Okay.
Whoever wants to start first, by all means.
I can go. Okay, so I have papers. I'm so fortunate to be in Illinois because I have talking points and they're really long. So I'll just make it just like big categories. So
we've got time.
The way Illinois legislatively, the legal rights for folks in our state, and I know we all think this, we're talking about women's health, and we know many of our pregnancy capable people do not identify as women. So wanting to be inclusive and acknowledge their identity. But there's things like the Reproductive Health Act, which gives the Illinois residents the right to full reproductive care. That includes abortion care, contraceptive, IVF. There's no parental notification required in our state. I'm turning the page. There's a SHIELD law, which is very involved. And from a general perspective, the SHIELD law protects providers. So if an abortion provider in Illinois goes to Indiana, their work in Illinois is something that's not legal in the state they are. What's that all about? So the SHIELD law, it protects them and the patients who are in our state continue to have the rights of others in our state. There's some things that have changed since Dobbs, which I'm really proud that Illinois, things have been more nimble than they often are at a state level, like the ability for folks who provide this care in banned states to get an Illinois license is a little bit faster than it used to be, and that's huge. Residents who are training in other states who all of a sudden could not learn this important standard of care practice can come from other states here. Neha is legendary in that space of training other people in a moment's notice. Sure, come on down and I'll teach you from Wisconsin. Illinois has expanded who can provide abortion care, including nurse practitioners and PAs, expanded birth center, like Karie was talking about, birth centers to, instead of just do prenatal and deliveries, to do full service care. So that's kind of the big category. It's really, I sometimes sit with other people from other states and it's this embarrassment of riches. We go in alphabetical order. I'm by Indiana, Iowa. I feel like I am so sorry because all those things are okay here. And then some of them are just things. Neha mentioned Carla. It's a hotline for providers to be able to have their complicated patients who need abortion care get connected to the right place to care for them. There's another hotline being developed for all patients coming from anywhere in the region or outside the region to be able to access where they can go to get abortion care in our state. So yeah, I have a lot of pages, but that's the big gist. So there's a lot that has happened on the state level and continuing to happen, preparing for what might happen politically upcoming.
No, that's fantastic. That's very encouraging to hear that the laws are doing what they're supposed to do and help people, right? We always like to hear that. I didn't quite catch the name of the hotline. I said Carla or Carla?
Yeah, it's called Carla. It stands for Complex. Help me out now. Complex Regional. I should know. Neha knows.
No. I was trying to get myself off mute. Complex Abortion Regional Line for Access, CARLA.
Carla. Okay, I was hearing that right. Just
It's
wanted
a
to confirm.
collaboration between the Chicago Abortion Fund, the University of Chicago, UIC, Rush, and Northwestern. So if someone needs hospital-based abortion care, meaning their underlying medical issues are too complicated to be safely managed in like a freestanding clinic, so like Planned Parenthood or Family Planning Associates. And I will say those institutions are really taking the largest burden of care from our out-of-state and in-state patients. Their influx and their capacity building has just been quite legendary and quite brisk as well. But for those patients that need more complex management, then they can just call this hotline, their provider, we have nurse navigators on the phone that will just help them assist with care, get records. It's very helpful. Because the other issue is that, and I know this is something that Maura, you guys have been talking about in IDPH land somewhere, the electronic medical record is both a blessing and a curse. As a provider, I have yearned for this for years. Please get me access so I can look at other medical records that exist. You know, it's hard as a patient to remember when your last echo cardiogram was, when your last EKG was. I don't, all of these kind of different issues. And so the electronic medical record has been such a helpful tool in that way. And now what we're seeing is that we don't necessarily want to share our records, and we want to be protective of our patients' records, especially if they're coming from restricted states. There are attorney generals in other states, the Texas, the Floridas, who are already attempting to sue and get records for patients that received sexual health or trans care in other states, saying that, well, they live in our state, so we should be able to get their records. So while Illinois has done a fantastic job, we have to remain really vigilant about and not be complacent about, laws will evolve, and the way that the attack on sexual health care is, the restrictions will also evolve to kind of counteract any progress we're making. Not to sound, kind of five-alarm fire, but just to remain vigilant.
No, that's I mean, even outside of healthcare, right? Data protection is every data is the hot commodity, right? Companies want it. Government, like every that's what we're fighting over all the time. So that makes perfect sense that it translates to reproductive healthcare, because why wouldn't it? I did want to touch on, I had one follow-up question, Maura, about I think it's very cool that we are providing training and reproductive training to people even out of state. I know all of you have done some work with various universities. Are Illinois universities doing anything at that level with students where they are making it a priority to highlight or provide training for students, our future doctors, nurses, healthcare practitioners?
Yeah, that I probably wasn't as clear. Especially OBGYN teach training programs that abortion care is part of the training. When the ban states, the day those bans were announced, clinics stopped, nobody could get, people couldn't access abortion care, and that meant the residents couldn't get that training and rotations that they would do that were part of their residency. So that's the way that, just in a really beautiful networks of colleagues in states where abortion remained, that a right still was present, residents in states that weren't are able to come and rotate. It's complicated. They leave their families. The receiving institution has to figure out how to make sure everybody gets the volume of cases they need to learn, but that is ongoing. And I think most programs have just done this really crazy free-for-all to try to call around and see where their residents can get the standard of care training, so that when they go out and practice, they are able to care for their patients.
Okay, thank you for clarifying. That's great. Lovely. So then amongst all these we've got places where the law is protecting, individuals, federal, Illinois, or otherwise. For us in the audience who are patients, what recourse do we have in advocating for our reproductive and our access needs? Like for those individuals who you said you're treating from other states and they can't really do follow-up care with you via telehealth, or they can't make it over, what what recourse do they have to make sure they're getting treatment of care that they need? Or what would you recommend as practitioners?
I would say vote, first of all, right? And then the other thing is I know it's just, I know this is what you guys do.
That's easy points with us. We love a vote.
Voting is nice. But also I have a couple things. So vote, but also if you have children or family that live in those restrictive states, recommend that they vote in those restrictive states because that is where they live. If you go to a four-year college, not in Illinois, you don't live in Illinois, your parents will always be your home. That is not what I'm saying, but you do not live here anymore, unfortunately. Your heart does. The other thing I will say is we should focus on existing pathways. So the Chicago Abortion Fund, I think locally is kind of the best way to act. You can also give money directly in time directly to your local abortion site. The Chicago Abortion Fund will help fund both travel, childcare, food, lodging, pay for the abortion services. So I cannot say about how much they actually do help. I have to pause for 1 second for my child.
No worries, not a problem. Karie, would you like to add anything to that point?
Yeah, and you're just really getting a landscape of the things we do in Illinois, but also, in other states, knowing that they don't have that access and supporting those so they get those laws changed for the better. I think what I also wanted to share was at the last point, University of Illinois and the College of Nursing, we received a $1.1 million grant from IDPH to do training for those who wanted to learn how to do abortion care. And we've been very inclusive of our nurse practitioners, our midwives, our family medicine docs who have not had that extensive training. And so we're putting that fellowship on right now as we speak and getting ready to train those because, we want those providers who need to focus on complex stuff, not to have to worry about the other conditions that don't warrant their attention that we could probably take off their plate for them. And so we're really trying to work together so we can not be so overloaded, and funding is key. I mean, to have the Chicago Abortion Foundation to really support the fund, support all of those entities is important. And that'll make sure that, folks get the care they need and not have to worry about those other entities that are hindering them from getting that.
Absolutely. It seems like it really is a group effort, which I will say when we were reaching out for panelists, we kind of contacted all of you disparately, but it seems like you're all kind of been working together already anyway, whether that's funding from the IDPH or I know Karie and Neha, you guys used to work together.
A nice little Underground Railroad thing going on.
Can I piggyback on that really quick?
Please do.
The question of what can patients do in advocating for their own reproductive health, certainly what's been talked about is essential. But one thing that I think that folks might not be aware of that I'm learning a lot as I work for the state is to ask your provider if there are any restrictions in that where they are. We know Illinois as a state is protective, but there are religious institutions that have to practice based on that institution. And so there are patients, and I'm hearing more stories about patients who didn't realize that they could get their tubes tied with their C-section. No one told them that they could do that. They weren't offered that service. So they have to, after they have their baby, have an additional surgery because no one shared with them, you can have this, just not here. So I think that folks, especially pregnancy capable people, need to find out, is that something not allowed here or is that not a thing? Because there are some places that don't potentially look like a religious institution, but have those restrictions. And often people don't know.
Yeah, no, that's a great point. Especially, I know certain hospitals have Saint whatever affiliated with them, and they only do certain procedures. I know the ideal is we all, trust our doctors, especially our reproductive care doctors, but it can be a sensitive subject. And also because it is such a contentious issue, do you have a recommendation of a safe way for a patient to kind of, ask their doctor these questions? Does it make more sense to just straightforwardly ask, do you provide a specific service, or more so of what do you provide for this area, or what does that look like ideally?
I think both, and hopefully your provider will say it, but I think are there religious restrictions at this institution? Because there are some that don't have Saint X in their name, but have been bought by a religious institution. There's regions of our state that when you look at a map, it's pretty sobering that the hospitals are all religious in quite a decent radius, and they don't all have names that would suggest that. So I think that just to ask the question, are there restrictions here because of the religious affiliation of the institution?
Oh,
That's a
that
good
makes
point. Our Southern Illinois colleagues are really marred by this. And it's hard. I'm from the Chicagoland area, so anything south of Chicago to me is Southern Illinois. So I'm gonna like walk that bias back a little bit. I will also say when you start a job, you should ask your job's insurance what is covered. Because just because you have X insurance does not mean that everything's covered. That includes contraceptive services, miscarriage management services, abortion services for any fetal anomalies. If you're in that position, you're starting a job or you have a job and you are thinking about kind of growing your family, to have those conversations with your insurance provider and kick it up to human resources if it is dissatisfying to you as an employee, because you are not alone in your job. There are other people that will be considering building their family or not.
No, that's an excellent point. So yeah, ask your doctor what's restricted and ask your insurance what's restricted. I think that makes a lot of sense, and that does really cover the main bases there. No, that's fantastic. Thank you for that
I want to
addition.
add to that.
Yeah, please.
The preventative care period is important. You're interviewing people to touch you, to care for you, to do tests on you, to use their expertise. And that's a vital time for you to ask those questions about what do you do, what services you provide. If I decide to do this, would you be able to assist me with that? And be very straightforward. And if this provider isn't someone you want to work with or think that you can trust them with some of the things that might come up in your life, then you want to do another interview with somebody else and get a second opinion, or to choose a different provider that fits your life. And so I think that's important when patients don't realize that some provider, even though that their entity doesn't restrict them from doing that, they personally may not do those things. And so we have to think about that, unfortunately, as well, and ask those direct questions about what they provide and what they are comfortable not doing.
No, that's great. That really is all three things: insurance, location, practitioner. I think that we got our bases covered there. No, thank you so much. So we're still okay on time. I'm going to get through a couple more of the pre-questions, and we've got some. I see some things being written in the audience. We've got some on here, so plenty to work through. So okay, actually, I think we've touched on this a little bit already. And it sounds, yeah. After the overturn of Roe v. Wade, there has been an increased concern over the restrictions of birth control, IVF, and other related treatments. Do you see the need for legislative protection of these or any other treatments? It sounds like we're already, we got some good protections already on the books. But is there anything in particular that seems to be more of a target these days that we haven't really discussed yet today? Say, Dr. Quinlan, if you want to start us off. Oh, no, go ahead.
I was just going to say the one thing, I mean, I think that the one thing that happened to be not related to Dobbs, but passed just around that, is the Illinois law that allows pharmacists to dispense hormonal contraception in a standing order of the director of IDPH. Which is great. So someone could walk into a pharmacy, go through the questions that we all do with our patients to make sure that their method of choice is safe for them, and the pharmacist can dispense it. We'd love for more pharmacists to have done the in-training to be able to do it. Many states have had that same problem. It's on the books, and pharmacists, not all participate. But that is there, and hopefully the uptake will increase, and it will just be another way that people can access contraception in our state without necessarily needing a provider visit.
That's great. Neha, did you want to add anything to that?
I was just going to say, I don't think that we can take for granted that things are safe, unfortunately.
Mhm.
You know, the restrictions have a couple effects. One is a direct, this is legal, this is not legal, but they leave a lot of gray, unfortunately. And the gray gives a lot of patient pause and provider pause about what can I do as a patient, what is legal here, what is okay for me to do with my body.
Mhm.
And then from the provider perspective, what kind of advice can I give this patient? Where can I give them a referral? How can I help them in the best way? So I think that a lot of these laws are spurring more of a fear. And so patients and providers are kind of self-selecting already. I'm not trying to be ominous, I'm sorry.
Oh, it's all good. Thank you for sharing your opinion. Karie, is there anything you wanted to add to that, the list of things that we would need more protections of that we haven't already have those efforts for in Illinois?
No, I think we've pretty much touched on those things. I think, we've talked about access and protection of, our labor and delivery units, our birthing centers, our, clinics in the neighborhoods that are unfortunately subjected to not having enough financial stability and tend to close, and then you leave these gaps in our neighborhoods. So if we could do more protection for that, and allow, patients to see individuals in their community and not utilizing the ER for things that we know we can only put up so many immediate care clinics and urgent care clinics. And so we need the full spectrum of services throughout our neighborhoods.
So that's like physical infrastructure then. And so that does bring me to this last question is, what role does cost have in prohibiting reproductive health care access? You don't necessarily need a law that prevents people, right? It could just be that there aren't the funds, things can't be covered by Medicare, Medicaid type of items. What do you, Karie, specifically, if there's anything like cost wise, aside from like facilities that you could point to as prohibitive?
Right. I mean, just trying to get to a location, not everybody has access to transportation. And so that can be an issue. You also have the fact that, we talked about telehealth, not everybody has access to internet all the time. And so cost is huge, and even in making sure that we have appropriate nutrients to fuel our bodies, whether it's for whatever reason, but for the sustaining of our good health no matter our health condition, we don't have access necessarily always to that. So funding is huge. It will make a big difference on outcomes, and wherever we deviate those funds to, it's important, the more, the better. But it would, it's nice in Illinois that we have, the laws that allow us to do the work that we need to do. But we could always use more.
Of course. No, great. Thank you so much. We've got a couple of questions here that I want to touch base on. So good questions. One question that came in from Stacy asking specifically about air travel. Air travel for care was mentioned. If a pregnant woman enters crisis in flight, is there an MM on board? What can be done for her? Do airlines have any restrictions on travel for pregnant women? I don't know if you guys are familiar, especially if you have patients, going to and from.
There's always restrictions that, again, remember when I said we have to do all these little maneuverings, I have to tell my patients, put this over your stomach so they don't pay attention, or don't say this, or don't respond there. It's crazy that we have to do all these things. But as far as in-flight situations, I would like to hope that they have some recourse, but I'm not for sure. You all know any of the help that's given to moms if there is an issue on the plane?
That's such a good question, and I don't know that it's happened, but is it the landing city? Is it the states you're over? Holy heck, that's a terror. If you look at a map of the country, that's terrifying and a really good question, and I don't know the answer.
Yeah. So
This
if
is
you
like
had,
my nightmare question. This
It's
is,
a nightmare
we just
question.
had a patient yesterday traveling from Texas with the,
Yeah.
that's why I brought up the example of who had broken their bag of water at 18 weeks and then boarded a plane to come get care in Illinois. And I always give them my general precautions of, safety. And I say, I can't recommend you travel or not recommend. It is an individual choice, which is what it is. And I think that's what we're seeing as these kind of rippling effects of these federal regulations, is that we're trying to not change how we counsel patients, right? Because we want to provide equitable care, but we are a little bit. We are being a little bit more hesitant in what we're saying, or a little bit more hedgy in what we're saying, because we want to be both safe and we're also worried about the legal landscape for our patients. I don't want that patient to end up in, the prosecutorial kind of framework, or the corrections facility. That's not what I'm going for, but I also want to make sure they're safe. So I worry about this quite a bit nowadays. It is giving me greater gray hairs, and we don't have an answer. This is one of those untested situations. My guess is that it would really affect what city that they're landing in, or what state they're landing in.
Oh, thank you for sharing. I have a question on, do you think that access to information and where to get access to healthcare is the first barrier to access? So in terms of education for patients, is there, or I guess is there anywhere you would point to as a first way to get information if someone has questions on their healthcare access?
I think that's huge, because if someone Googles abortion services near me, some of the crisis pregnancy centers, which is a whole nother conversation, but that is not a true clinic. That is a fake clinic. It doesn't provide that care. That's probably too strong a term, but it is a religiously affiliated, looks like a clinic, but does not provide care. If you Google, sometimes that's what comes up. So that would be extremely incorrect, tragic place for someone to go to, thinks that they're getting full service care and they're not. So things like CDC, Planned Parenthood, some of those sites you would get more straight answers. And again, the religious institutions, I would just caution that sometimes things won't be listed. And if someone doesn't know, they would think that's not an option, and it's just not an option there.
Gotcha. That makes sense.
And I urge you guys to get involved in your local school boards, because, where we start out is education, right? Education for young people. And so learning about sexual health care when you're in school, which is a lot of young people's first kind of glance at it or glimmer at it, is really important. So as school board elections kind of go on throughout the year, depending on your district, I really do recommend looking at that and taking an active part, especially in your hyper-local community.
Absolutely. And then, so this question, I think this would be a good question for Karie. Do you see a difference in the number of people seeking care from midwives in recent years? Is that different? Is there anything specific to variations in different cultures as well?
Well, I think what we also have to realize is traditionally midwives were the first providers of care a long time ago, centuries ago. And so traditionally that may be something that people are accustomed to, but then word of mouth, people, understand that they've had this experience and, oh my goodness, I want to have this experience too. And then they seek out a midwife, and, the curiosity of having this type of centered model midwifery care is what they seek, feeling like they're, heard more, and their opinion is included and their desires are respected and they're listened to. And that's just the way that we've been taught in providing care, and people appreciate that. So the upsurge is because that's just what they desire. Now, do we not work with our colleagues closely? absolutely do all the time. Let me tell you, I have lots of MFM wants to be there and complex abortion providers as well. And so, those things that come to me because in the neighborhood that I serve, we don't have access already to an MFM who's in-house all the time, or we don't have abortion care already set up. And so I have to be able to orchestrate and get them to those facilities that will get them the care that they need. But midwives do a lot of things, and we have lots of friends that help us do a lot of things, and we appreciate that.
Oh, that's fantastic. Thank you for sharing. And then this is a big one. What can I do to prepare for the possibility that a loved one from out of state may want to or need to come to Illinois to get reproductive care? Is there anything I should know in advance so I can help them as quickly as possible or in an emergency?
I would say,
Neha, you want to go first?
yeah, I would say first be there for them as a loved person and as a family member or as a friend. I think that is the first thing, seeing what they need. And if they need access to care, they can always call Carla or they can always call Planned Parenthood, Family Planning Associates. These are very well regarded and safe institutions in Illinois. If they need financial assistance, the Chicago Abortion Fund is an amazing place to start and see if they need any care. But I would say first and foremost, be there for them as family and a loved one. Because many times we kind of switch into kind of taking care of business mode, and some people need some more space and time to think about the decision and think about kind of how they're going to manage it. And it could just be that, they can get to where they need to go, but they really would love for someone to take their child to their soccer practice so that they can feel kind of more continued and stable in their home life. That's my only advice.
Great. Maura, would you like anything to add to that?
No, I think that was great. I think that especially if someone's coming from I guess it depends on what they need, but I think if you could reach out to your own OBGYN. My niece has got, they need an IUD or whatever, like something that they aren't able to get in their home state. That would be someone who knows you to help them get their care.
Great. And Karie, if you want to add any last additions to that advice?
No, we've stated the different entities that are available to us, but we have to be supportive of what our family and loved ones want to do or don't want to do. And so I think just being present in the moment is very helpful, and all will fall into place after that.
That's fantastic. No, thank you so much. We actually are coming up on time, and I want to give our president some moments to thank everybody. But you guys have been great today. Thank you so much for your time and your expertise. And I'm going to pass things over to Gail.
So like many of you, I have been involved in many, many Zoom meetings. I don't think I have ever felt such compassion, such passion coming through a screen like I did tonight. I mean, it almost brings me to tears. That if you can do that through a Zoom meeting, I can't imagine the kind of care that you are delivering one-on-one in your communities and in your patients. As a fellow person from Illinois, thank you, thank you, thank you. The League is proud to be a nonpartisan, neither supporting nor opposing candidates or political parties on any level of government, but we are always working on issues of concerns to members of the public, which is why we are here tonight and why we are joined with the Schaumburg Library as our partner in these civic awareness events. We thank our directors, Terry Gazowski and Janet Sonoika, for bringing this with us, as well as Chris. Next month, the issue will be gun violence prevention. We'll be exploring gun violence through the lens of domestic violence and the social and economic circumstances that often lead to that. That will take place on Tuesday, November 12th. But there is something that is happening in November prior to November 12th, and that is on November 5th, the election day. And to quote our doctor, vote, vote, vote. And to help you make that decision on locally for whom to vote, we are conducting later this week 2 candidate forums. Thursday, October 10th, at the Barrington Library at 6:30. There will be the Illinois House 52 district, and that is candidates Martin McLaughlin and Maria Peterson. Immediately following that at 7:45 is the Illinois House 51st district, candidates Nabila Syed and Tosi Ufodike. Again, we thank you for your presence here, and I'm going to say next month, you are going to want to be in this room because it is really exciting to be here in person. I know it's lovely to be online, but it's really wonderful to be here in person. If you have any questions about how to vote, anything about a sample ballot, any of that, you can go to the League of Women Voters website and you will find many, many resources. Again, thank you for the evening.
Thank you so much.